Right, so those of you that don't know me, I'm Gary McAllister. I am the Chief Technology Officer for London and the Chief Information Officer at Guy's and St Thomas's Hospital, but I have just left the national team as the longest title in history of the Director of Technology, Strategy, Architecture and Standards. So don't say it after 10 pints because it swaps about a bit. Right, so I want to talk to you about a few things that I was working on before I left. I think it's really important to note that some of this stuff may or may not be published. Some of it is my own opinion, and I'll try and be explicit as I go so that there's no confusion. And then as we come towards the end of the conversation, I'll give my opinion about how we should move forward with the kind of connecting of shared care records, which is one of the kind of key things that we probably need to achieve in England at this point, and as well as the United Kingdom. So the border problem already been described. So when I was asked to go and work in the centre, I was given the opportunity to develop a target architecture, was the phraseology at the time. And after a bit of mulling over what target actually meant, kind of realise that there never really is a target architecture, and what you need is a process. So I'm not going to go into prolonged amounts of detail around the kind of the views that were put forward and the consultation that happened to get to this map. But we did start with a very swift process of engaging with leadership across health and social care to get to a view as to what is it that people actually need and where should that sit. And there was a lot of consultation around that. And then there's a few capabilities that we developed. I'm not going to touch on all of these, but I think it's really important, just picking up on Lorraine's comments and work, is that, and then the National Clinical Data Repository is an example, using standards and evolving information standards so that you get a clinically led design process before you capture information, so that it is always of high quality when you try to use it, is a real kind of vital component that you need in your toolbox. In London, we're lucky enough to have one now. We've worked with the PRSB to conform elements of our information model in London as part of our Universal Care Plan programme. I don't touch on that either in this presentation, but it just reinforces that when you have a standards-based approach, you get the data, you use the data, it makes sense to a clinician, and then the value of that data almost becomes self-evident when you try and use it in the future. And the data quality problems actually disappear because it's designed by clinicians for clinicians, and it really benefits the patient as well. But there's two parts to this. That I'm going to talk about today is the National Record Gateway, which is a concept that is currently in the proposed national architecture documentation. It may or may not see life, but I'm here to talk about the way forwards, potentially, and then the National Record Services. So the two of them, as we talk about, a roadmap to the future, one probably should lead to the other. So slightly contentious, some of it, and I'll come on to the terminology and what it means now. Because the National Record Gateway, conceptually, is about connecting what we've got and having a single point of access for shared care records in a hub and spoke model, effectively, nationally, which enables us to then use the multitude of standards that have been adopted and deployed across our communities in order to get a single unified view. There's a number of reasons why that's good, or at least a best endeavours view as to what we can achieve based on all the shared care records that are created. Because we took, one problem and we made it 42 problems, and now we've got to try and make it one unified problem, or at least one unified view when we bring it all back together. The National Record Service, I think, is, in my opinion, probably the long-term goal in order to achieve kind of the if you like, the nirvana outcome of record management for England. You look at other big health systems now internationally. Australia probably has got probably the best vision, but a lot of them are now starting to coalesce on single platforms for the core health record itself, and then federating out the more difficult bits. Slovenia have had a CDR in place for a very long time. There are other parts of Europe that are doing very well as well. France have just got a £2 billion programme to try and make sense of all of this stuff using international standards. But for today, we'll talk about the Record Gateway, which is really about how do we bring together the shared care records and what standards should we use, short, medium and longer term, and I'll touch on those as I go, in order to get to what the Record Gateway is, which is in your mind. Please see that as like the tactical 5 to 10 year piece of work in order to connect stuff up on a best endeavours basis, and then the record services, which is going to take a huge piece of aspirational architecture and investment, and as I said a moment ago, may never see the light of day. So connecting care together. So key to this today for me, the presentation is about how do we move things forward together based on what we've already got and what we need. So some of you will already be using the National Record Locator. It's a valuable piece of the national architecture. It provides the ability for you to push a pointer into a single registry nationally and then use that list of documents in order to see information at the point of care. The challenges around the National Record Locator are fundamentally it doesn't store anything, so it's always about quality of service at every endpoint. And then as you try and deploy that, if you've got many hundreds of endpoints, you've got many hundreds of quality of service challenges. So what we've done with our shared care records is we've tried to tackle those en masse, and we've tried to connect everything into hubs, and then we've provided those hubs to people. But NRL is being used for immense value for mental health, for ambulance transfers of care and things like that at this point. And it is one, I come back to like the jigsaw has many moving parts to it at this point, and what we need to do moving forwards is try and coalesce those in order to get the best outcome. And I think that's probably key to the next few slides that I'm going to present. So on the basis that there isn't really a national architecture to connect shared care records at this point. We have NRL, and then we've got our stuff. And our stuff is a mix of everything, and I'll present the kind of the semi-mix of everything on the basis of what's there and prevalent today. Some of the views need to change. So coming back to in order for us strategically to solve the bigger problem, we do need to reset some of the mindset around where data should sit. And I think the mindset around direct care and where data should sit probably needs to be reinforced and re-established in the centre, especially if you want a record service. I mean, for a patient today, in order to go, I mean, in the 21st century, for me, it's why can't I go and see all my appointments in one place? Why can I not go in, excuse me, why can I not then get all my orders that have been placed on me and the results that have been placed on me and correspond with my clinicians and all this stuff that you'd expect? Because the NHS isn't that big. We've just made it very complicated. So moving forwards, I think nationally there needs to be thought around what does sit in the centre and what we should federate out. NRL, I'm not going to dwell on it because it's a fundamental part of the national architecture, but it has its place. I just think for a collective, we probably need to be a bit more ambitious, and we need to be more ambitious about how we tackle the problem. And part of the challenge, I'm going to be upfront, like part of the challenge at the moment is that the consensus around doing this stuff is hard. So because the way that, I suppose this community, I'll try and use my hands to describe it, but you've got this vibrant community, which is very well established now, is creating events like this, done amazing work, federated across the country. I was in the centre for nearly a year. We had very little representation from this community and the real conversations that needed to happen in order to get to the right outcome. So, I have a belief that the community needs to be more involved. So in order to ensure that the right experienced voices who have done the work, implemented shared care records, and actually got the experience, the scars, and have you know, Sarah touched on it very, very vibrantly at the start, overcome the hurdles and the challenges and know what it really takes to connect stuff up. We need to do that together with the support of the centre. So what I really wanted to talk about as well is, you know, some of the debatable points, which comes back to the issue above. And there's kind of two core camps, really, when it comes to standards. You've got, let's say camps, it sounds really like combat all, if you like, but you've got the kind of extreme modernisation, which is, you know, everything must be fire, everything, you know, must have been, you know, developed in the last 12 to 18 to 24 months, which we never went in the real world. We don't really work in that way. We work with what we can get. Like you know, these systems aren't mature. They're very difficult to work with. So the expectation of everything must be fire is really difficult when you're trying to do the right thing, because it doesn't exist. The nirvana doesn't exist. So and then you've got the IHE camp, which you know, is profile driven, outcome driven, almost very standards orientated in its own right. But the way that developed was, you know, 10, 15 years ago. So how do you do the right thing and make everybody happy in an environment where there are too many voices and no one is ever going to be happy? So the debatable points are really difficult to overcome. But again, I think the community should have the voice when it comes to making the decisions. And that's really where kind of my standards debate kind of finishes today, because I don't think it's right for some of these problems to be concluded in the centre. I think it's really important that it's concluded in the community, and then the centre supports community decisions. It's not how it's working at the moment, so it needs to change. Equally, I really like the point that Sarah raised at the start about, and Lorraine touched on it, about the shared care records that we've got today. My experience in London is there's a lot of stuff in there that if you try to apply it to the standards that exist today and present it across the country, you wouldn't be able to fit it into those standards, because we've got random documents and mental health care plans that were never designed against any standards. We've got, you know, horrible APIs that, I won't name names or suppliers, but horrible APIs where we're ingesting what we can get and then turning it into something that we can present just so that the data gets, and that kind of stuff is not, that's not really a standards problem. That's an implementation issue that sits with the vendors of these systems, because the standards are there, they just don't use them. So there's a realism of some of this that I think we need to bring back to the conversation. And whatever we develop, if the information is valuable, the standards shouldn't really matter. It's about how you get the information to the point of care. And I think sometimes we lose that when we talk and get very in-depth on standards and technical conversations, because they're not really relevant to a clinician, and they're certainly not relevant to a patient. So I'm kind of then taking this conversation a step further and raising around the fact that we don't really have a single architecture either. So we talked a bit about NRL a minute ago, but then you've got these kind of three key patterns of implementation that exist across the country. Again, I'm not going to go into immense amounts of detail. Some of them based on older base standards, some of them based on more modern standards with, you know, with intermediary layers that convert from one to another in order to present something to an end user. But ultimately, if you've got lots of stuff and you want to provide one thing, it's a hard problem to solve. Hardest. It's probably the hardest, nearly the hardest, based on your definition. Right, so this is where we've got to. So before I raise the one final last challenge, Sarah and the team have been helping my national colleagues on where we get to next and what the National Record Gateway could look like on the basis of where do we go from here. So on the basis that we've got no real implementable standard that exists that would uniformly apply to every shared care record, we've just established that. On the basis that there is no unified user interface that we can ingest this information into, we've established that. On the basis of, you know, we've got a challenge around the community and the decisions and the governance, we need to resolve that. I'm kind of asking the group today, and one of the challenges I'm bringing to this community is, I think it's about time the community owned the problem. So I don't know how long I've taken on my presentation, but I'm going to close on my last slide on that note. So I'm really here to try and make a call to action to the shared care record community, because I think we've got a real opportunity, new round of funding, new government coming along. There's a bit of money around at the moment in the centre. I really think that with this community, we could take the problem of the National Record Gateway, we could accelerate it through local ownership, local control and local delivery. And we've got the right expertise in this community to make the right decisions in order to drive this forward. So I'm hoping, off the back of my attendance today, support from the community itself and the stakeholder communities around the community, we can drive this agenda forward and make a real difference to the clinicians and the patients. So I'll finish there. Shane?